Well, hi, everybody. Welcome to today's webinar. It is titled Applications of Lean Leadership Methods in Home-Based Care. I'm Mark Graben from Value Capture. We are very pleased to be hosting the webinar today. Thank you to everybody for attending or for watching the recording once that's available. We are very pleased to be joined, and I'll tell you more about him in a minute, our presenter, Cooper Linton. He's an Associate Vice President with Duke HomeCare Hospice. Let me tell you about our presenter. Again, he is Cooper Linton. He's an Associate Vice President at Duke HomeCare Hospice. Cooper has worked in healthcare for over 20 years with a passionate focus on home and community-based care. His professional background includes strategic planning, healthcare operations, certificate of need, marketing, business development, and healthcare construction. He currently serves as the Associate Vice President for Duke HomeCare, Duke Hospice, and Duke Home Infusion. Cooper also hosts a podcast. He co-hosts a podcast called Edge of Aging, which is focused on healthcare and aging issues. He has a passion around healthcare access for the medically underserved, as well as a desire to enhance access to services for caregivers. Cooper holds a master's in healthcare administration and a master's in business administration from the University of Alabama at Birmingham, where he also completed his graduate certificate in gerontology. Cooper believes that his greatest real-world education came through his role as a caregiver while he shared the care journey of his parents. And as you'll see on this next slide, when not working, Cooper is happily busy as a husband, father, and an avid outdoorsman.
Thanks, Mark. Appreciate it very much. I'm happy to jump in if you're ready for me to go, Mark.
Well, we see you as one of your outdoor roles on a boat. Yep. And we're happy today. You're also an avid indoorsman. So I'll turn it over to you.
Thank you very much. It's a lot easier to do this indoors today. I think you can tell two things from this. One is really enjoy spending time outside. We have a 15-year-old son, and he and I were out fishing. I think we can come to agreement quickly that I have no business taking a selfie and then sharing it with anyone. So let's move to the next slide. The idea around this is talking about applications of lean leadership, but applying them to home and community-based care. And we typically think of lean in other settings. And I have to admit, when I came to my first experience with lean, working with value capture, I came into it with some misconceptions about what lean was. It was, to me, associated with everybody going into a small room and putting stickies on the walls or trying to learn Japanese words for things. And it was a little overwhelming and off-putting to me, and it didn't feel like it was something we can do. And I hope in this discussion, it'll make sense to you that not only does it apply to home and community-based care, it's something that is very achievable by any of us. You may need some help getting there. Most of us need help doing something, but it's very achievable to look at rolling this out, and there's some benefits for it. We've already done an introduction to me, so we'll skip that. But I think an introduction for who is Duke HomeCare Hospice and Home Infusion. We operate all three of those businesses in one entity. And I think it's important to understand that as for some context, as you look at how may this apply to your organization or to an organization that you wish to apply this to. We run an average daily census of those three programs of around 1,900 patients on any given day. We do offer home-based care, home-based Medicare certified home health, a Medicare certified hospice to include a freestanding inpatient hospice facility, an IPU as it's sometimes called, inpatient unit. We also have our own compounding pharmacy and home infusion. So there's a home care license in North Carolina as well. And from that, and a board of pharmacy, obviously we run our own pharmacy. So we have a full-blown home infusion and compounding center. Our geographic service area, for context, we're a certificate of need state. So the defined service area for home health and for hospice is around 4,400 square miles. With respect to home infusion, we can actually cover all of North Carolina instead of the 9 counties earlier. We cover all of North Carolina, all of South Carolina, all of Virginia, That means we cover 128,000 square miles with respect to home infusion. I don't know how that may apply to your individual organization, but I hope it gives you some context for how we begin to apply the lean principles at Duke or in Duke home-based care. We had some fundamentals, though. Before we jumped into our journey, we had some fundamentals. And I think these fundamentals are things we would agree to if we were all a group of strangers and we weren't separated by COVID and distance. We could probably agree to some of these things quickly. One is an intrinsic respect for our staff. And not just saying that we're going to use the word respect in our values and stick them on a wall, but that turns into an action of how we guard, use, protect, resource the time of our staff and their expertise. As we face shortages in clinical care and clinical staff, I think we've never been more sensitive to time as a resource. We also were focused around commit to zero, which is the Duke phrase, but it's really committing to zero. We call it a Duke, but it's the idea of that no one should be hurt in the provision of care or in the receipt of care. And we see that reflected with the Joint Commission. That's not in any way unique to the Duke University Health System, but that's a core tenet of us. No one should be harmed in the provision or the receipt of care. We wanted to eliminate waste, error, rework. That ties back to respect for time. I mean, if we truly are respectful of time, what we don't want to do is cause people to waste it doing things twice. The other phrase, and this may be more of a personal pet peeve, everywhere I've worked in my life, we've talked about addressing issues. We need to address an issue. And we find that in 5 years, we've addressed that issue 8 times. Well, then we've never resolved it, solved it to root, spent the time investigating what the concerns are until we've winnowed it down to what is critically important in making this problem never happen again. And so being focused on the idea of resolving issues and not just addressing them. Our focus on zero harm or commit to zero was fairly broad. When we start talking about that, I want to unpack that phrase a little bit. Our discussion around harm was pretty broad. It wasn't simply a physical harm to a patient or a physical harm to a staff member, though that absolutely counts. We wanted to include harms to people's loved ones, their caregivers in the home, not necessarily our professional caregivers, but their caregivers in the home, their family members, the emotional state of those people, obviously our staff, and then also our business. If fundamentally a harm to our business is a harm to our mission, why is that acceptable? And we began to look at risk differently as we went down that journey. I mean, we first start with harms, but then we begin to narrow that, actually expand it more, and look at what does it mean to be focused on risk. And we often pat ourselves on the back for good catches. And we said, well, that was a close call. We had a near miss. Well, what these really are harms that have not materialized to patient impact or human impact yet. The problem is the yet part. So I think we're going to come back and talk about that a little bit more. But we're going to really focus thinking about how do we address risks to keep them from ever becoming harms. The first place that we began to roll out lean principles, the most tangible way, was to begin to put in a series of safety huddles, or what we call tiers. Tier 1 for us is our frontline staff, people that are patient contacting or immediately patient impacting were our tier 1. And the idea was to prioritize the feedback of that staff, what they needed to do their work, to clearly identify safety issues right then, right now. There's a sense of urgency in that, and understanding what they needed for the support of their work. And so we created a tier 1. A tier 2 is then the leadership or the management of the staff that had the tier 1 meeting. And there's an escalation of issues from tier 1 to tier 2. Tier 3 for our organization is the senior leadership team. And we do meet daily with an eye toward escalating issues. And there's a spirit of urgency in getting this done. One of the things we also include, besides some basic statistics and understanding harm, is a focus on catching people in moments of excellence. Or as we say, caught being awesome is kind of the term we talk here. The language we use. So we talk about catching people who are doing things that are beyond the normal expectations and bringing that forward. We also bring up good catches, both to celebrate them, but also to recognize them as a risk. Now, immediately when we started talking about these tiers, the concern was, well, how much time is that going to take? Isn't that going to require lots of time on our calendar and require us to do things? The answer is absolutely, that's true. We're going to be respectful of people's time, but it doesn't mean it will take no time to do this. It does take time. What it is not, however, is necessarily additive time. And so as we begin to look at the work of our frontline staff, our mid-level managers, and our senior leadership team, we're spending that time doing something now. Let's have a conversation about restructuring and repackaging that time in a way that is more focused and more rapidly responsive. And that's what the tiered structure gave us, was a mechanism to put that in place. And it does mean that we're going to clear our calendars at times because there's an escalated issue that then trumps whatever we thought we had on our calendar after that. It's a change not only the way we deliver information, but the cadence of our work. And it gets very focused on doing things right now. Information is perishable. My recollection of breakfast this morning and my recollection of breakfast 2 weeks ago are materially different. Information is highly perishable, and there's a need to go see what happened, understand what happened, and to do it now. I want to share in this next slide some pictures of our huddles. Now, the point of this is not to show the absolute colorblind, that we really just colored crazy on some of this. That did make it fun, and there's stars, and it's kind of whimsical in a way, but it's also very focused. If you look at the first whiteboard on the left, which was a literal whiteboard with black tape on it, this was our first foray into doing a tier. It was dry erase markers on a whiteboard with postcards or note cards that were magnetized on little clips. It was very tangible. And this was done in our inpatient hospice facility first. We started there before we ever went to our larger home-based care. We started in the inpatient facility first with these concepts of tiers, and we cut our teeth there. And so we could do it in person. But it's important to understand that everything in this is iterative. We should all be in this iterative learning process. The whiteboard on the right was our second iteration of trying to make a whiteboard. And what we did was we created something digitally that basically looked like the one we had done in real life. The problem is it didn't work that well. And it had lots of information, but there's a little bit of chaos to it, right? For me, it takes some time to train the eye to focus on what are we looking at here? What are the patient harms? What are the new problems? What are the root causes that have been identified? What are the items that have been escalated? Which ones have been resolved? What are just do-its? And we'll talk in a moment about just do-its. Our next huddle slide, or our next virtual slide, is a true virtual whiteboard. And this is now set, this one in particular is set up in Smartsheet. And I just grabbed one from a couple months ago, and I took one tiny snapshot for one business line to share with you, because we wanted to have a platform which was virtual, that was attainable by anyone in our organization so that they could see it from their phone, from their laptop, from their workspace at the office, or for those that are working from home. There needed to be a ubiquitous nature to being able to access the huddle board. It shouldn't be hidden. And so we wanted to make it virtually public. And as you can see on here, you can see this was our one for home health. We talked about our patient harms, our employee harms. Next says admissions greater than 2 days. Why is that on there? Because we have determined that if it takes longer than 2 days to admit anyone, we consider that a potential harm, a risk, and it deserves to understand why. And so literally there is an explanation for every one of those. You can see in the third bar, there were 3 patients that day from the previous day that had slower admissions. We unpack every single one of those as a potential harm. We want to know our census, our COVID population, those that are COVID patients at risk. You can see it capacity challenges because that's directly tied to our mission. Good catches, as we referenced earlier, you could call them close calls if you want. And then celebrations, people caught being awesome. But this is a virtual piece and it's translatable into the community-based environment. And this was part of our ability to move from a building of care to the decentralized care model of home-based hospice, home health, and home infusion. But we needed a mechanism that didn't require all of us to be in one place. And we're continuing that model to today. We continue to refine those huddle boards. Everything is iterative. Now, we talk a lot about A3s, A3 being a kind of a language of lean that's really around problem solving, understanding, going through a process of understanding the problem, unpacking it, doing a problem analysis, identifying the ideal state or the target condition in that upper right-hand quadrant, and then really getting down to the action steps. When we first started this, we wanted to jump from the upper left-hand quadrant, which is the current state, current condition and background, and we wanted to jump immediately to the bottom right-hand side. Here's our problem. Let's jump to solutions. We weren't spending the time that it took to really boil down the problems, to do the problem analysis. Sometimes it's called asking 5 whys, which is a great tool to do that. But it's really understanding to root what the issues are. And it's usually not that somebody's trying to do a bad job. Most people aren't showing up to work going, hey, it's Tuesday. I wonder what I can botch up between now and noon. They really want to do a good job. But we created barriers, usually unintentionally, to the achievement of their excellent outcomes. That upper right-hand quadrant, as you know, is our ideal thinking. And then we get into our action plan. The part that mattered more to me than, and you can see this one's just a piece of paper stuck to a wall. We do some of them in electronic format, but the format doesn't matter. I would even say that what matters most isn't the 4 quadrants, but it's changing the way we think about A3s to where A3 becomes a scientific thinking approach in the way we look at work in general. It's got to go from being a 4-quadrant worksheet to being a leadership culture in how we address problems when they're identified. And to be clear, when you begin a process of going through these tiered huddles, you will find more problems than you ever thought you had. In fact, you're going to be overwhelmed with problems because people now are like, hey, I finally have a mechanism to express my concern, to escalate an issue for help. So then how do we solve them? And how do we prioritize them? I included this quote from the French playwright. I like it enough that it's actually at the top of the leadership agendas when we meet. It's not only for what we do that we're held responsible, it's for what we do not do. And it's been phrased in many different ways. In fact, there's different faiths actually have a prayer of confession that includes language similar to that. It's really about recognizing what we've left undone. And I would ask that, do we really overestimate the risk of our or underestimate the risk of the status quo and overestimate the risk of taking action? And it actually hinders us. When we get caught in this process of trying to make it perfect before we implement it, as opposed to recognizing that it is going to be perpetually iterative, and liberate ourselves from trying to define the perfect prior to implementation. I'm not suggesting that we be rash or hasty, but that we fully recognize that there are risks associated with our status quo and that the risk of change may be overstated. Now, I bring this up because we talk about how are we going to manage all this with our executive time. I don't have time to do this. And I think every member of our team felt overwhelmed by the time expectations when we started this. The fact is, we've cut our executive meeting time, I said here, by 50+%. The truth is closer to 65. We have found that there were many non-valuable things we met around. And we did something known as quit doing that. We just stopped doing some things that we thought had to be done a certain way. We quit meeting about them. We reduced our executive meeting time and repurposed that to this time-sensitive, more urgently responding method of escalating things through our tiers and then taking action. Our executive team now meets for 15 minutes, Monday, Wednesday, and Friday after our tier 3. You would be amazed at what happens in those 15 minutes. What's interesting is we rarely ever use all 15 minutes. Our efficiency is now that, okay, the meeting's over, we're done. Or only certain people need to stay behind because we're focused on the problem solving, not focused on having a meeting. Or we spend 2 weeks preparing an agenda to talk about something that happened a month ago. It's a real shift, and that's that A3 problem thinking, problem solving approaches. Now, when we think about how do you apply this to home-based care, because much of this applies everywhere, we have some real challenges. It is harder to do this in home-based care in some respects. For one, we have a remote workforce. I mean, one of the first slides I shared was that conservatively our service area is 4,400 square miles. And for home infusion, it's 3 states. So how do you navigate having this done? Well, you couldn't have 10 years ago. But my guess is everybody on this webinar has a smartphone. You may be watching it on your smartphone, or you may be sick of me and you're looking at your smartphone. Either way, you've got one, and it's amazing how many of our people actually participate in tier through their smartphone. They pull over the side of the road. We have a laptop. We give them. They use the hotspot. But people are able to do this whether they're at home or they're somewhere out in the community. There are complications of lone worker scheduling. For those of you that are familiar with home-based care, scheduling is the greatest nightmare we've ever had. I've heard people say, well, that's not directly patient contact. You try doing patient care without a schedule. Our schedulers are the unsung heroes, and it's incredibly difficult work. Time limitations. As soon as we pull time out of the day, we're impacting the visiting schedule of staff who rotate and drive from home to home. We want to minimize that. I would also submit, though, that we don't track the time that we currently waste by not solving their problems. And so we have overestimated the impact of pausing for 15 minutes and underestimated the impact of allowing waste and rework and frustration to build. And it impacts staff satisfaction at a time that staffing has never been more critical. The heterogeneity of the care setting. If you go from one wing of our hospice IPU to another wing, it's almost identical. The same is true for many hospitals and most direct care settings where they're in facilities. But if we're doing this in the home, every home is different. When you've been to one home, you've been to one home. And we go to over 1,850 homes on any given day. We also know that home care has a greater risk of injury and harm to our staff than in almost, not all, but almost any other setting of care, largely because of the care settings, the amount of travel. So we have an opportunity to reduce risk, reduce harm, and improve the safety of our very critical staff. There are some significant challenges, but by doing this in a remote format, it allowed us to incorporate our staff. I want to touch on another piece of this. We have been in this journey for about 6 to 9 months when COVID really began to blow up. Now, COVID has been wearisome, at times overwhelming. For many of us, there's times we felt like we were watching a freight train. But we were better prepared to address COVID because of our early engagement on the lean processes and our commitment to zero harm. Our focus on zero harm was about eliminating harm and identifying risks and solving them to root. Well, COVID is nothing more than a different form of harm. It required a great deal of nimbleness, and we had begun to eliminate some of the inefficiencies. And I want to be clear, we are nowhere close to the end of that journey. We're still struggling with inefficiencies, and we're still getting better at this. But our motion on that journey allowed us to be more nimble and better prepared us to navigate the constantly changing requirements of COVID-19. Whether it was changes in testing, changes in our approach to keeping our staff safe, the impact of decentralizing a workforce, sending people to work from home, whatever it was, we were more nimble on that. We were focused around our frontline staff needs already, and this became one more need. We had the mechanism in place. And what we also had was we were beginning to develop at that point greater confidence in our abilities to get these things done. We'd already had some successes. And so there was some emotional resilience that came out of it. So what are the outcomes, Cooper? That all sounds great. You've got a spreadsheet and your guys are having tiered meetings. Well, it's not just the tiered meetings. It's more about changing the philosophical approach to problem solving in the organization and involving our staff in solving the problems. One of our biggest problems was our billing register, which was cut by 60 to 75%. By understanding what our staff needs were and trusting the intentions of the people involved. We quit blaming who was causing the problem and unpacked the broken processes that were causing everyone to struggle and to be dissatisfied. We reduced our nursing turnover by over 50%. 50%. By hearing our frontline staff say, "This is burdensome. I hate this." And I will tell you, they will sometimes say it in ways that we won't share on this webinar, but they're sincere. It's authentic feedback. And we needed to hear it, and we improved the way we delivered care. Our staff is now expressing far greater satisfaction. The fact that they're not leaving is the greatest, but they're telling us they're happy. They understand the process they're going through because they helped design the changes. They know they were part of the solution. That in itself leads to cultural change. Our frontline staff are engaged. There is a baked-in mechanism for engaging them every day. We actually start the conversation about safety, about frontline staff engagement, and about our commitment to XERO in the huddle system. We start that conversation in the first hour of their employment. They get a tour of the building. They find out where the restrooms are. They meet our leadership team, and our leadership team introduces these ideas to new employees within the first 60 minutes that they're employed. We want to start early. What it's also caused is a real change in cadence. Our cadence previously had been a little sleepy. We had been slow. That's also known as unresponsive if you're a frontline staff member. You don't feel valued and heard. You don't feel like someone respects your voice, your time, your opinion. We needed to improve the speed of our decision-making and our responsiveness to the needs of our frontline staff, not only through the escalation process, but through solving things to root so that issues didn't emerge and reemerge until slowly we grind people down. My takeaway from this, my takeaway for you in this is that this is not a project. I've heard lean described as we're going to implement some lean stuff, and that's going to be our project for the next year. I would challenge that as fervently as possible. This is a fundamental shift in the way we begin to think, solve problems, turn our staff into problem solvers, and cease being the problem solver ourselves. Is a fundamental change in the way we begin to think, lead, and engage. If you're going to go into this, you have to be fully committed. You can't go part of the way. It's like crossing a river. If you get halfway across and quit, you will be swept downstream. You really need to fully commit to it and get to the other side of changing the way we think. What you thought you knew probably doesn't matter, and you may want to check that at the door. If you tend to be encumbered by a pretty large ego, I would encourage you to check that at the door as well, because there's some pretty humbling experiences that go on through this as you make yourself a member of the team and a coach and pull yourself out of the hierarchical leadership role that we've often been baked into for years. Get ready for a mess. It's coming, but our staff are already dealing with messes and they want our help. If we can get in there with them, it turns out they can actually help us solve them and solve them quickly. If I would encourage you to bring in somebody who is a coach, and I use the term coach, not consultant. Well, we need to hire a consultant. I don't use those terms interchangeably. A consultant is often someone that you bring in for expertise to teach you something or show you how to do something you don't know. They have subject matter expertise on how to put in a new electronic medical record. Pick something, it doesn't matter. They come to you with solutions. A coach helps you find solutions among your staff, among yourself, and then you are implementing your ideas. Now, you do need some help in the process. You're going to get stuck. You're going to need some assistance breaking down barriers, or frankly, breaking down the way you used to think about things. The biggest barrier for me was not solving things or trying to solve them the way I had before. I've always thought of myself, my value was what I knew. I'm going to be an accumulator of knowledge, and that's the value that I bring. This has really begun to shift my self-view as a leader to think of myself as a perpetual learner and a perpetual adapter, and that my role is to coach and shift my knowledge base to the knowledge base of others. It'll help if you bring somebody in with fresh eyes. Now, we've covered a lot of ground in what is about 30 minutes. So if you're interested, my email is on the bottom there. We've got a Q&A session coming up here in a second. But not everybody's comfortable asking questions in public, or you think about this tomorrow evening, or you go home tonight and you're pondering it. I would love it if you were thinking about this tomorrow evening. But send me an email. We'll set up a time, we'll chat, and we can share our experiences. And it may be that you need to speak to someone else on our team besides me. I think I'm the furthest from some of the real issues that have been solved. So being able to talk to some of our frontline team members is something I want you to feel like you have access to. And remember, this is a team sport, not just here at Duke, but it seems like all of us that are on this call are in a team sport. We're trying to make things better, all of us, or we wouldn't be on this call. Mark, that's all the slides I have, unless you want me to show that goofy fishing picture again. You need.
No, I think we're going to have a really good Q&A session. Hey, I'm not good at taking selfies either, so maybe there's a course, somebody that can help us with that, but I feel you. But I really appreciate everything that you shared here. We'll let you get a sip of water and catch your breath, and we're going to have a real good Q&A session here. But before we do that, just a couple quick announcements, if you can advance it, please, Cooper. Great job on the presentation, of course. I want to tell you just briefly about value capture. We have a recently launched website. You can learn more about us and the work we do at valuecapturellc.com. We are a trusted advisory firm. As you see here on the front of the website, we support leaders who seek to dramatically improve the performance of their healthcare organization toward what we call the theoretical limits of performance. And this includes coaching people toward zero harm. Coaching leaders, I think we fit Cooper's definition of a coach versus a consultant. So we'd invite you to learn more about us. We have free ebooks. We have a blog. We do a podcast series that Cooper and his colleague Benita Pope were a part of. There are free white papers and case studies. Again, you can find all of that at valuecapturellc.com. Two of those featured ebooks, if you can advance it, please, Cooper. Two ebooks, Wisdom from Paul O'Neill Sr., who passed away last year. There are two books, both free to download. One is called The Playbook for Habitual Excellence, and this is a compilation of the transcripts of some speeches, I think some very powerful and insightful speeches that Mr. O'Neill gave over the years about improvement. And then there's a second ebook called Lasting Impact, Leaders Share Lessons from Paul H. O'Neill Sr. And that is written in a style where there are a number of quotes and stories from people who were directly impacted by the coaching and the leadership of Mr. O'Neill. So you can download both of those. They are free. You can go to valuecapturellc.com/both-books if you want to get those. So if you can advance it again. It's time for Q&A. So you're ready to go for that, Cooper?
I think so. When you know, ignorance is something everybody's ready to share. So,
no. I'll coach you through it. It's okay. But you
Thanks.
have experiences to share. One question is, what year did this journey get started? And looking back at that, like, what's something that went really well that you would repeat in those early days? And is there something that you would do differently?
So we actually started in late 2018. And one of the things that I would change is that it took me a little while to understand how to imagine this applying to home-based care. We went down this journey as the Duke University health system, and we began to open up pockets of these tiered huddles and this A3 thinking. We had one of the Duke entities which had been doing this for a number of years, and there was an effort to duplicate that. And Value Capture actually was a coach for a number of us in the organization as we began to open up pockets of this around the university health system. It was very focused on facility care, clinics, hospital floors, ICUs, surgical areas, and that made a ton of sense. But I spent a while floundering, trying to figure out how do we truly take these concepts and repackage them to where they make sense here in a more distributed form of care through home and community-based. I struggled with that. One of our colleagues, Mark mentioned Benita Pope, is on the podcast. She is the director of our hospice program, incredibly insightful individual, and was able to really work with us. She kind of took a championship role, and we began to look at how do we roll that out. And we did it through trial and error. Hey, what worked? And you can't be afraid of failure. I think my own fear of not doing it right the first time acted as a barrier to getting started. And I would not repeat that if I could.
Okay.
What else, Mark?
So there's another question here. When you talk about encouraging people to speak up, to point out risks or near misses or worst case harm, what are some things that you and other leaders do to make it safe for people to speak up about that?
So I think you can tell people all sorts of stuff. Hey, we're not, we want to hear your voice. That's important. The words should match it. But ultimately, it's our behaviors as leaders that are going to define a culture of whether people feel safe bringing things forward. And part of it is going out and seeing what happened. Too often, I think we get relegated to our offices, to our Zooms, to meetings with a group of us that are always meeting together. It's some subsect of your leadership team that's always together. And to set that down and make part of our daily job to go be with our frontline staff. And that presence, that familiarity begins to break down some of the barriers that our organizational charts unfortunately create. If I show up on a tier 1 huddle, no one's surprised anymore. Because that's what I do. Well, Cooper, do you have anything to say? No, I came to listen. I'm going to tell everybody good morning, but I really came here to hear what's going on at front line. And if it's a direct care setting, you're there. And so you start having this engagement, and soon people quit paying attention to whose job title it is, who from what level in the organization is on this tier and walking this floor and showing up in this meeting. And it really becomes we all go to each other's work and we all learn from each other. And suddenly it's a subconscious change in culture. It's subtle, but it's powerful. And then people start telling you stuff. Yesterday at lunch, I came out. I wasn't taking a lunch. I walked out of an office. I had a CNA who was standing outside my door and said, "Can I talk with you?" I looked at my calendar. I said, "Yeah, I've got a few minutes. What's on your mind?" A CNA came in and sat down and had a conversation. There was stuff on her mind. Now, we're not going to disempower that individual's leader. We're still going to respect that. But what we've created is shared access, not only for our staff to their leadership, but more importantly, our leadership having access to the minds of our frontline staff.
Mhm.
Sorry, that was a long answer, Mark.
No, well, that was a good answer. Building on that, when you talk about not disempowering people, I know you encourage people to get better at solving problems. You're also listening. Things are being escalated. So can you talk about the types of things that get escalated versus things that you try to keep within the team? Are there some criteria that are used? How do you figure that out?
Well, it often depends on how comfortable they are sharing their own problem. And if they're effective at it, we would like for them to share that solution elsewhere. So hopefully we don't all have to keep reinventing the wheel, right? I'll give you an example that came up this past week. We've had an issue with needing to move patients from their setting of care at home to inpatient settings where we're not able to manage COVID in that particular setting. So there's a need to test that patient. And licensure can be a little different in different states, but we realized there was not a great solution for rapid in-home testing that we had confidence in the test quality. So that was escalated by our frontline staff who felt like that the barriers to patients getting these tests were negatively impacting the speed of our response to their medical needs by slowing down their transport to certain settings of care. That was escalated. Our frontline staff said, "This involves things we can't fix ourselves." And they immediately asked for help. Interestingly, I was rounding the next night, actually, and one of our frontline staff members says, "Hey, can I talk to you?" I said, "Sure." They said, "We're having an issue with getting tests." And so at home, before we transfer patients in, I was hearing it from the frontline staff in person, but I'd actually already heard about it escalated. And by the time our frontline staff had caught me, it had been through our tier. We had brought in our help chain, which involved our laboratory services across the health system, began to look at CLIA waivers and trying to solve it. We're not going to ask our frontline staff to understand CLIA waivers as they apply to COVID testing. So that gets escalated. Other things we find people solve themselves. They just needed permission to do it, including what needs to be on their huddle boards. There's times they realize, hey, we're not always tracking the right stuff. We're missing things. And they make changes in their own huddle boards based on their own experience.
Great. And I'm going to ask you one other thing, Cooper, since it's just us talking, if you can stop the screen share.
Oh, I'm sorry.
No, that's okay. I should have asked you to do that.
Oh, there we go. I can see us now.
It's an opportunity to add that to our standard process for next time. That's quite all right. So we've got a question here. How does the commit to zero approach compare to current industry standards or benchmarks? Or maybe part of the question is, like, what data do you look at around harms? Do you look at how your data compares to other organizations, or is the focus just where you are versus zero?
And the answer is yes to actually both of them. If we're beating everybody else's data, we still believe we're not as far along as we should be. So we are benchmarking against ourselves. We are also grabbing benchmark data, and we compare ourselves to quartile, decile rankings from similar organizations around the country. We found that not always are we comparing apples to apples. And so we had to become more particular in the data we were getting. All hospitals are not the same. All doctors are not the same. All home health agencies, hospices are not treating the same cohort of patients. There may be differences in disease distribution, acuity levels, et cetera. So we began to find data that we pay for. We purchase access to data, and we run our data against that and then drill down. So it is very quantitative in that perspective. And we use that to create our own benchmarks. I don't think that's unique, though, in any way to us. My guess is that's going to resonate with almost everybody on this call. Mm-hmm. What we don't ever, there are things that we can't get other people's data on. Mm-hmm. And so, for example, we'll never know how many shipping errors another home infusion company has in the course of a year.
Yeah.
But I can tell you how many we want. We would like 0. So that's what we strive for.
Yeah. You don't know how many near misses there are. You don't know how many identified risks there are at other organizations. You might not even know how many harms there are.
We didn't know how many we had until we went down this process. I mean, one of the first challenges you have is you get overwhelmed. You've created this mechanism for an outlet, people asking for help, and you've got to be prepared for how to triage that. And it took us a little while to winnow that down and say, what are our priorities going to be?
Another question about metrics and maybe also priorities. With your, what current quality metrics do you use? What are some of the key quality metrics around patient satisfaction, outcomes in care?
So we use, for hospice and home health, we use the CAPS program, very similar to everybody else. We also look at other benchmarks. So we're looking for anecdotal information. We're looking for issues that are being escalated from our frontline staff around patient satisfaction or dissatisfaction long before it ever turns into a survey, long before it ever turns into a complaint that ends up in a complaint log and all that. It's good to have those pieces. We also find that we're having to track data that we identify. We, for example, have always tracked line infections, which makes a lot of sense if you're running home infusion, but we track them in the other business lines. We also realize, though, that falls matter differently, whether they're in a care setting or a patient's home. Are those really the same? And we had to do a lot of work around understanding falls, observed and unobserved. And when was that in a Duke setting? When was that with a Duke employee present? And when was that reported to us 3 days later by a family member who may not be a great historian? So we had to begin to look at parsing out something as simple as a patient falling down. We had to look at that differently. And we created some of our own benchmarks, things that we believe are criteria. Our own definition of readmission appropriateness is much tighter than the industry standards. We've held ourselves to a higher benchmark and we created our own. Nobody wants to go back to the hospital. They don't go back for the food.
Can you, well, you talk about, wanting to go back to the hospital, needing to go back to the hospital. Can you share a little bit more? This is maybe less about lean and just more about the context in which you're working. The things that are being done to keep patients out of the hospital, preventing admissions or readmissions. What impact does that have on costs and then reimbursement?
There's a lot of pieces in that question, Mark. Thanks.
Let me take one at a time. Sorry.
No, it's all right. It's a great question. For us, the issue isn't so much about reimbursement. Let's start with the mission concept of we should be delivering the absolute highest level of care to a patient we can. And if we can keep them out of a hospital doing the appropriate things, we should. We're part of a large health system. Because of that, we have a hospital that doesn't want readmissions either. If you're a standalone proprietary home health agency or hospice, you may not feel the same pressure that a hospital does when the hospital already has compressed beds and you're sending patients to the ED and they're not sure what to do with them. So we may have motivations that standalone organizations don't. But fundamentally, unless a readmission is necessary for the care of that patient, isn't it just a harm? It's an increased risk of facility-acquired infection. It's an increased risk. It's an emotional harm for most of these patients unless they truly want to go back for security issues. We want to minimize harm and risk. And so how do we do that appropriately? And some of the things we began to do were doing remote patient monitoring, not in any way unique to do. People are doing that. But what's the criteria? How are we running that? How do we make interventions when we get readings that are unusual? What is the role of our staff in identifying risk, and how well have we trained them to identify risk based on patient behaviors? I would submit that no one knows your patients as well as your home health aides or your hospice aides. The ones that are doing the most intimate personal care know that patient's behavior better than anybody except their family. How tuned are we to the feedback of our aide care? They can be the canary in the coal mine for us.
Okay, thanks. Another question here says, Cooper, one of the things that struck me about you, Benita, and your team, how you've built and used the system of continuous improvement, is how it's allowed you to get people away from trade-off thinking. In other words, if we pursue one goal that's good, we have to set aside another goal, or there's trade-offs. And instead, realizing that making processes great allows good things, all of these good things, to happen at the same time. What are your thoughts about that observation?
Well, I think sometimes we forget we're making trade-offs by our inaction. And that was really what I meant earlier by we overestimate the risk of change and underestimate the risk of the status quo. We're making trade-offs that are not intentional, but they come through just accepting them. The static inertia has a trade-off, and often it's terrible. If we look at the impact on our staff and our patients, if we also look at the impact on our organization's bottom line, if we lose money, and there's times we do, and there's times we make, but when we lose money, it harms the mission of our organization. Have we shared that with our staff? Do they understand that? So when we think about that, these trade-offs, realize there aren't as many trade-offs. We're often falsely creating that. And if we can embrace change that's fed by scientific thinking and from frontline experience, we will accomplish many positive results at the same time. There is still a need to prioritize. When we started being overwhelmed with all these ideas coming forward, we knew we couldn't do them all at once. As a leadership team, we created a series of 4 priorities that we actually keep at the top of the agenda from every leadership team, that and the quote from Moliere, that we use to make decisions. Because we're going to have to make some tough decisions, and we need to come to agreement on what those priorities are as a team. Not whimsically not what's today's motivation, not what was on my mind when I woke up this morning or the last email I got from a large health system. What are our priorities as an organization that we can agree on and use those to help us figure out where we're going to place our resources next?
Okay, thanks, Cooper. Another question came in, going back to the beginning of this journey with the organization. Did you provide training to all levels on lean and other concepts to start? Then second question, part of this, how did you know your organization was ready for this work?
Those are 2 great questions. The first one, yes, we did provide training. One of the things that we did, and I think this was actually through the coaching of your team, Mark, of your folks at Value Capture, was our leadership team went through training at multiple levels of the system, but also here locally. The hard part then became that we had to become our staff's trainers. Mm-hmm. You think you know something until you have to teach something. And then you truly begin to learn it. And I think most of us have experienced that. So by putting ourselves in the uncomfortable role of trying to learn and then become the teachers and coaches for our staff, it did 2 things. And one made us learn it better. The other, it created immediate buy-in. Someone else isn't coming to our program and telling us what to do. We are doing this ourselves. So that was the teaching and training part. What was the second question?
Yeah, well, I'll read you that part again, but yeah, I just want to comment. I mean, what you're describing there of starting with the leadership team and then having that cascade down through the organization, that's a different approach you see in a lot of places where someone's maybe brought in from the outside to train the frontline staff, and then at some point hoping to influence leaders. And I would share, the observation, the hypothesis that plays out that it's more effective to have something be leader-led,
it's got to be
coached through that, right? Can you share a little more about that?
It has to be an internal locus of control. You can't have somebody come in and do this for you. That's the difference again between the consultant and the coach. The coach helps you do it. The consultant does it. This had to be ours, because at some point your coach, your consultant, your outside party is going to say, okay, guys, we've done what we can do. We're going home now. We have to keep that living and alive. We have to figure out how to refine it and make it better next year than it is this year. That's ours.
Mhm.
There has to be absolute ownership in this. And and that ownership turns into engagement. And also, we always talk about, how do we get staff buy-in? If the staff are doing it, you don't have to ask how to get staff buy-in. The staff's bought in. They're the ones doing it. You don't have to get them to like your idea. It's their idea. By the way, they're pretty smart. I'll share with you. You didn't ask this. I got caught in my old thinking the other day. We had a problem in our distribution center, and we needed to restructure. We were having some errors, and it was overcrowding. There were some safety issues, and I flipped into my old problem-solving mode. I'm going to solve this. I know about building. Sure, I can do this. And after about 2 days of not solving the problem, I walked down to the warehouse, and a gentleman by the name of John, who's here today, showed me the problem. He took me through the problem, and in just a few moments had the solution himself, which I had the privilege of helping to implement. But I wasn't going to solve this problem. In fact, I had incorrectly identified the problem. And this is after doing this lean journey for 2.5, 3 years. I fell victim to my own way of thinking, and it only took me 2 days to totally screw something up. It took John about 10 minutes to set me straight.
Well, hey, at least you're open to that, because we fall back into old habits. Old habits are hard to break sometimes. That's certainly
we all do it, and it really is about checking the way you were thinking at the door. Where you're going to be uncomfortable going down this process. What has mattered to me is it's so worth it. It's so worth it. We have so many problem solvers now.
Yeah. Now, the second part of that question was, how did you know your organization was ready for this work? Or how much of that was the thought process? Are you ever ready, or at some point you just have to go?
I think we can overanalyze that. I think sometimes trying to get ready is a unintentional way to avoid embracing change. Oh, I just need to be ready enough. Well, when are you it's time to do it, because you're never going to be ready. Your status quo is not effective. If it's not working well now, you're ready for making it right. What are you waiting on? And I think for us, we were struggling a little bit with that. Now, there were some basic structures. We need to be sure we didn't have too many open positions. But I think we can overanalyze, when are you ready? Because starting problems, we all have problems. We're ready to solve more problems today. And we still have plenty, to be clear. We didn't wake up in some sort of utopia. We've solved every issue in home and community-based care. Not true.
And as you said earlier, there's risk of action and there's risk of inaction. There's risk of maintaining the status quo. And I think you made that point really well.
It's a cultural thing too. Do we punish failure, or do we celebrate people trying to find a solution? And if we create a punitive environment and then ask people to experiment, we're not going to get them to experiment. Who in their right mind would?
They're not going to.
If I make a mistake, you're going to punish me.
Right. Yeah. Quick follow-up question, and we're almost out of time here, about the training. What was kind of the length and depth of the training that you got as a leader and that you were then teaching?
So we spent over a period of several months getting training, kind of in sections, because you need some time to go back and practice. You don't need somebody talking to you over your shoulder every day, all day. We broke it into where we met with our coaches X number of hours each week, and they came in and did some trainings. They taught us how to do trainings. So the upfront training process went on over about 6 weeks. We then went into check-in periods, and I will tell you, up until recently, I was still checking in with a coach from Value Capture, and to this day would reach out to him in a heartbeat because there were times I needed somebody to check my thinking. Cooper, is that really the best way? What have you asked this? What about this? Having someone else ask those questions in a way that's not putting you on your heels makes all the difference. So I don't think we're ever out of training, but we become more independent.
Yeah. Well, I'm glad you're still working at it. That's an important part of continuing the journey and continue working towards zero harm. So Cooper, thank you for everything you shared, both in the presentation and in the Q&A today. So again, we want to thank Cooper Linton from Duke HomeCare and Hospice. Really appreciate you taking the time. Thank you, everybody, for attending. Please, share the recording with your colleagues, and really, thank you again for being here. Thanks, Cooper.
My privilege. Thank you, Mark.